Hello, this is Peggy O'Connor, and this is part 2 of the acute respiratory disorders in children, and it's covering the respiratory assessment. When performing a health history, the first thing that you want to obtain is the past medical history. So you should ask about a history of recurrent colds, sore throats, if the baby was premature, if there was any respiratory dysfunction at birth, poor weight gain, a history of recurrent respiratory illnesses, or chronic lung disease. You also want to obtain a family history, and you would do that by asking about significant chronic respiratory disorders like asthma or infectious exposure. The next step is to ask a history of the present illness. So you want to ask about the onset and the progression of the present disease, whether there's been a fever or is a fever, if there's nasal congestion, noisy breathing, presence and description of a cough, rapid respirations, if there's been an increased work of breathing, is there ear, nose, sinus, or throat pain, ear pulling, headache, vomiting with coughing, poor feeding, lethargy, or exposure to secondhand smoke. The next step is where you perform your physical exam. And the first part of that physical exam is inspection and observation. So you would assess the color of the child, the nose and oral cavity, cough, and look for adventitious breath sounds, respiratory effort, look for retractions, assess if the baby has any anxiety or restlessness, look for clubbing in the fingers and toes, and also to assess hydration status. The second part of the physical exam is auscultation. So you want to assess the lung sounds over the anterior and posterior chest and along the mid-axillary line. Note the adequacy of aeration. Normal breath sounds are tubular and equal bilaterally. They also should be softer and longer on inspiration than on expiration. Prolonged expiration is a sign of bronchial or bronchiolar obstruction. Wheezing is a high-pitched, and it usually occurs on expiration as a result of obstruction of the bronchioles, so it is a lower airway breath sound. Rales are crackling sounds that occur when the alveoli become filled with fluid, as when someone has pneumonia. Note the location of adventitious sounds and the timing. Is it on inspiration, on expiration, or both? During your respiratory assessment, I have talked about adventitious breath sounds. Adventitious breath sounds are stridor, which is high-pitched upper airway closure, or narrowing. Wheezes, I have just described for you, and they are lower airway, and crackles, I have just described for you, and they are lower airway. Respiratory mechanics are when you're going to look for nasal flaring. And in this picture that I have shown you, here you have normal nostrils. They are not widened. In this side of the picture, you have flared nostrils, and this is nasal flaring. And it can be mild, it can be moderate, and it can be constant. Grunting, I have a video down below that's going to show you retractions and grunting. Grunting is a way that the baby is forcing air to come out, and they do it and it sounds like grunting. Assessing work of breathing, interaction with the environment, hydration status, and vital signs are all part of your respiratory assessment. So we can give a score for respiratory assessment. We would give them a 0, a 1, or a 2, and we would assess chest movement. Are the respirations synchronized where both chest and diaphragmatic are going up at the same time? If there's a lag on respirations, you're going to see the chest and abdomen go up with a downward movement of the subcostal, and that's subcostal kind of retractions that you would see. Also seesaw respirations, where the belly goes up and the chest goes down, then the chest goes up and the belly goes down. Then you would have intercostal retractions. So if there are no intercostal retractions, that's a 0. If they're just visible, that's a 1. And if they're marked, that's a 2. Looking for a xiphoid retraction. So that's a retraction that's also called substernal. And if it's none, just visible or marked, and you can kind of see it on the baby, and the video clip that you just saw should show you. The nares dilation, so this is your nasal flaring. If there's none, a 0, minimal, a 1, and 2 if it's marked. And then if there's an expiratory grunt. If there's no expiratory grunt, it's a 0. If it's audible only by stethoscope, that's a 1. And if it's audible by unaided ear, then that's a 2. I have put in a picture here of where you can see retraction. So you can see them suprasternal, right above the breastbone, and you'll see a depression. Supraclavicular is right above the clavicles, and you'll see it depress as they're breathing in. Intercostal, you'll see the depression between the ribs. Substernal or xiphoid is right underneath the xiphoid process, and subcostal is when you see a depression underneath the ribs. This is a baby who is actually intubated, but what this picture is showing is it's showing the seesaw retraction. So you can see that the belly is elevated and the chest is depressed, and you can actually see a marked substernal retractions. There's another YouTube clip here for you to look to show. It shows retractions and seesaw retractions. So again, synchronized respirations, a lag on respirations, and seesaw respirations. The third part of your physical exam is percussion. Note that sounds that are not resident in nature. Flat or dull sounds would be heard over partially consolidated lung tissue. Tympany would be heard over a pneumothorax, and hyperresonance would be heard with asthma. The fourth part of your physical exam is palpation. Palpate the sinuses for tenderness in the older child. Look for enlargement or tenderness of lymph nodes in the head and neck. Document alterations in tactile fremitus, which might occur in cases of pneumonia or pleural effusion. Fremitus might be decreased if a child has a barrel chest, where they would have cystic fibrosis, which is a topic that Lisa will be covering. Absent fremitus would be found with a pneumothorax or an atelectasis. Compare central and peripheral pulses. Note the quality of the pulse and the rate. And if there's significant respiratory distress, perfusion can be compromised. And poor perfusion can be reflected in weak peripheral pulses, both radial and pedal, as compared to central pulses. So the outcomes that our nursing interventions should obtain are decreased work of breathing, maintenance of a patent airway, absence of trauma or infection, resumption of age-appropriate level of activity, adequate fluid intake, reduction in anxiety and confusion. We want optimal growth and development, and we want to reduce any evidence of pain on an age-appropriate scale and using non-verbal indicators. So one of our goals is to achieve adequate oxygenation. So to do this, our nursing interventions would be oxygen delivery by any one of a variety of methods, and it is considered a medication and requires an MD order. Efficacy is evaluated by respiratory effort, liter flow, and the proper use of the equipment. We want to maintain a patent airway. We want to position the child in the sniffing position if they're supine, so their head really elevated. Humidified oxygen or room air. Ensure adequate fluid intake. Use a bulb suction or nasopharyngeal suction before bottle feeds, and an MPO status if they're tachypnic so that they will not aspirate. In an older child, you can encourage them to expectorate sputum with coughing, chest PT if it's been ordered, and ensure that emergency equipment is available. We want to promote effective breathing patterns. So reassess the respiratory breath sounds and work of breathing frequently. Use pulse oximetry. Use position of comfort and pillows to maintain the position. Administer supplemental oxygen plus humidity. Allow sleep and rest periods. Administer antibiotics as ordered. And encourage incentive spirometry and deep breathing and coughing. And in a younger child, you have to be very creative. So you might want to use blowing bubbles or blowing a pinwheel. We want to promote adequate gas exchange. So administer oxygen and monitor O2 sat. Encourage secretion clearance with coughing, expectoration, chest PT, and suctioning. Administer bronchodilators as ordered. Provide support to the child and family, and monitor the child's mental status for confusion, lethargy, restlessness, or combativeness. We want to prevent infection, so maintain aseptic technique, good hand washing, limit the number of visitors and screen them for recent illness, administer antibiotics if they've been prescribed, encourage a nutritious diet, taking the child's preferences and ability to feed into account, droplet precautions as they're needed, and teach preventive methods like hand washing, covering the mouth and nose when coughing or sneezing, and the proper disposal of used tissues. We want to maintain adequate fluid balance, calculate the daily maintenance fluid requirements for the child, administer IV fluids as ordered, and encourage PO intake as ordered. Monitor for signs of adequate hydration. The best single method for monitoring hydration status is a daily weight. In addition to that, assess skin turgor, the mucosa for moistness, the anterior fontanelle should be flat, and adequate urine output. And in a young child or baby, it's 1 ml per kilo per hour. They're on strict I&O, monitor urine-specific gravity, serum and urine electrolytes, BUN, creatinine, and osmolality as they've been ordered. We want to promote adequate nutritional intake, daily weight on the same scale at the same time of day, encourage high-calorie, protein-rich foods, offer the child's favorite foods, and play games to increase their food intake. Consider performing calorie count for 3 days if their intake is poor. We want to increase activity tolerance, so provide rest periods, group your nursing activities together, provide small, frequent meals, encourage quiet activities, and then allow for a gradual increase in activity while keeping the oxygen saturation normal. We want to relieve fear and anxiety. You need to establish a trusting relationship with the child and the family. So for the child, that means getting down to and using the child's developmental level to help build trust. Explain procedures at the developmentally appropriate level. Provide their favorite blanket or toy, and incorporate comfort measures that are preferred by the child. Involve the parents in providing care to their child. We want to promote adequate family processes. Encourage parents to discuss their concerns, explain the therapy, procedures, and any behavioral changes that are seen in the child. Encourage parents to be involved in the child's care and for them to take care of themselves. This is the end of part 2. You should continue on to part 3, which begins the different diagnoses.